Good morning, good afternoon, good evening to everyone. Welcome to this call, which is talking about basic occupational health services. We have three excellent speakers today from India, Thailand, and the Netherlands, so we have a good geographic spread. I first heard about basics when I went to India for the occupational conference in 2019, and I thought it was a very interesting concept then. And I was presented with one of the books that they have, which lists all of the different trades and jobs and lists all the health hazards and the occupational diseases for them, which was absolutely fascinating. And I learned about jobs such as biddy rollers that I hadn't heard of before. So this is a kind of a concept looking at how we provide occupational health services for the informal sector and for the large numbers of people in countries around the world who are working away from the kind of the larger companies who already have their own occupational health services. So very much looking forward to what our speakers have to say. We will be taking questions at the end, so we'll have the three presentations first, and then we'll have questions at the end. If you post your questions in the chat, I'll try and gather them together and direct them to the most appropriate of the three speakers at the end. So our first presentation is BOHS working towards occupational healthcare for informal workers by Dr. Suvarna Moti. Dr. Suvarna works as a public health specialist with Reliance Industries. For those that don't know, Reliance is a big conglomerate, industrial conglomerate in India, and she advises on occupational health, health policy, and strategy in community health and occupational health. She completed her postgraduate training at Grant College, Mumbai, and also obtained an MSc in global health policy from the London School of Tropical Hygiene. Of Hygiene and Tropical Medicine, and she's worked as plant medical officer at Hindustan Unilever and as all. Dr. Suvarna.
Thank you. Am I audible?
Yeah.
Okay, great. Thank you, Will. And thank you, SOM, as well as IOMSC for providing this platform to give some visibility to a concept which has been available for the past 2 decades, nearly more than 2 decades, and is a very important concept towards bringing in healthcare, occupational healthcare for the informal industry. So I will be sharing my thoughts with you regarding an experience that we've had in bringing and attempting to bring such a service in our country. What were the barriers, what were the challenges we had, and how did we go about it? So the experience stems from the fact that I have worked as a technical expert for this mission BOHS, and we try to popularize it, bring it about, and try to bring about a change in the attitude and thinking for delivering these services. So let us roll. A little bit about how I'm going to structure my presentation, considering that I've got about 22 minutes with me. I will be taking you through the process of understanding what is informal economy and the occupations which fall within informal economy within the country, and how Mission BOHS was conceptualized and what did it attempt to do, what were the learnings and the recommendations which emerged out of it. Now, when we talk about informal economy, it is understood that it is a part of an economy that which is neither officially taxed nor monitored, and informal workers are workers who have no written contracts, they have no benefits, either health or leave or social security, and we are looking at an emerging group of workers. Now, workers are workers which either work through platform-enabled services like Ola or Uber. Those are the taxi drivers. So they use digital services, digital platforms, softwares, or those who continue to work out of traditional occupations but without written contracts or so. And these are some of the examples of gig workers. And this gig workers, the numbers are swelling rapidly over the past few years. And it is becoming quite a challenge when we talk about delivering services to a group of workers in the country when it is amounting to more than 80% of the overall workforce of more than 500 million people. These are the informal workers which are responsible for producing half of India's GDP. And very sadly, even after 75 years of independence, they're still languishing and suffering and continue to be underserved in terms of occupational health care. Now, a little bit about the occupational healthcare delivery system in India. Now, in the country, what we have is we have the division of subjects or division of areas of interest for the country in three lists. You have a central list, which is a union list. Then we have a concurrent list, and we have a state list. What does this actually indicate? It indicates that subjects or areas or disciplines which fall in the central list or the union list are the responsibility of the federal government. And items which fall in the state list remain a responsibility of the state governments or the provincial governments. So health is a state subject. And surprisingly, what has happened in the country is occupational health, which might be true of some other countries also, occupational health falls under the Ministry of Labor. Ministry of Health, which is the supreme body responsible for the policy formation and implementation of various health initiatives across the country and giving a direction to the thoughts, they are not responsible for delivery.
So this is are you going to share your screen? Sorry.
Oh, I'm so sorry. Am I not sharing the screen?
No.
Oh, excuse me.
Thank you.
Thank you. Thanks for pointing this out. Okay. So, sorry about that. So, while referring to the occupational healthcare in the country, as I mentioned, it is a decentralized, fragmented delivery, and this service is not integrated with the primary healthcare. There are no occupational health clinics available in the public or private hospitals. We have about 35, 36 policies, like latest, the Occupational Health Code, which is still awaiting execution. And the Factories Act, which is responsible for the manufacturing industry, there's a statutory requirement for occupational health clinics that falls within the organized sector. The organized sector has the benefit of having organized occupational health services, and the enforcement is through the factory inspectorate and the factory engineers. But the informal sector does not have any delivery system, and there is no registration or enforcement compliance is required. So in brief over here, let us just touch upon the various challenges that are observed here. When we talk about the lack of registration, lack of legal framework for registration of workplaces, no employment data, employers' disinterest and profit motives are supreme. There is no organized workers' movement. There is no trade unions. There are no trade unions which are actually there to push this workers' interest areas also. Social security coverage is inadequate. And there is a very strong feeling. There is the awareness among workmen about health and safety is pretty low. They are rarely covered under the various labor surveys. And the most important factor is because of the high population density, low skilling of work over here, there is easy replacement of labor. So how does it translate into the challenges for actual delivery? In that respect, what we see over here is there is a focus in the various health programs on biomedical approach to health. The importance to socioeconomic determinants is pretty low, and the medical technical approach is favored. It is more reactive and it is more favored over the preventive and promotive healthcare. Now, the various surveys and the needs analysis which go on, they also have paid less attention to occupational health needs. A very important factor is the capacity building in this stream is pretty low. We have only 21 training institutes producing about 500 qualified personnel, where the requirement is almost 10,000 per year. So the deficit is wide. The penetration of health insurance at various levels, be it the government insurance or the social insurance or the private insurance, hardly 37% of the population is covered with it. And a very important factor is the out-of-pocket expenditure, because the public health services, the quality of services is sometimes circumspect. So there is low utilization of public health facilities and more utilization of private healthcare, causing medical debts and causing out-of-pocket expenditure for the informal workers to rise. So now it has dropped down to 47% from 65%. Moving on, when you say that this sector, this employment is providing almost half of the nation's GDP, then is it not an important national capital? Then how can health system support this capital? And that is when the visibility and the requirement for basic occupational health services to integrate the workers' health needs with the primary care services was felt. It was a felt need. In BOHS, the focus is upon elimination, prevention, and control of hazardous factors in the environment, in the work environment. And the objective is provision of services to all the workplaces, irrespective of whether they are organized sector or unorganized sector, whether the workplaces have existing services which are not satisfying the demands, or there were never such services provided. And health equity is a basic premise with universality, that is adaptation to local conditions and making it affordable in various ways. Now, when we talk about basic occupational health services, how is it conceived? So what is done is basically you analyze the prevailing situation and then decide what is required, what are the strategies to be utilized. In that respect, since you have limited resources, you cannot have a wide coverage. So what do? In that respect, what you do is you try to go in stages. You apply the stepwise approach and you adapt the activities to local conditions. Now, if you notice carefully, this is a stage-wise approach which is provided by Professor Hormar Rantanen, who was a big proponent. And in his seminal work on basic occupational health services, he has talked about this continuous development of the health services to cater for basic occupational health services. If you see on the right, there's a diagram which is showing the various activities which are covered under the basic occupational health services. And this was always the focus to be delivered. So the Indian Occupational Health Services, Indian Association of Occupational Health, IOH, conceived the Mission BOHS. And this Mission BOHS was conceived, it's a voluntary organization with industrial medical officers as its members, along with some academicians and representatives from the ministry. And the goal was providing BOHS for populations working in the unorganized sector with some very specific needs. The advantage is we decided to utilize the primary care system. In the primary care system, you have the primary health center medical officers, then you have general practitioners and employee state insurance physicians. This is an organization which provides services to workers who are above a certain salary level also. And this is basically an occupational health service in the formal informal category also. But this is an accessible service. So the objective was training this primary care providers. Training was to be provided by industrial physicians on a voluntary basis, and fully bearing in mind the fact that every primary health center caters to 25,000 of population in the rural area. So this becomes a win-win proposition. How did we go about this? This was the way it was tailored, that we know what are the local conditions. We have identified needs of the target groups, but which are the target groups? So there was a task force which was employed, and this task force, along with the technical expert group from the government, identified about 22 occupations. And I'm sure you can see the listing of the 22 occupations over here. The predominant one was agriculture, and it stretches up to BD work, driving vehicles, midwifery, working in scavenging, working in leather and tanning industries, and so on and so forth. Now, the first aspect was creation of the task force. The second was creation of a training manual, because there was no literature which was available or training models available to train these primary care providers. Now, please bear in mind, these primary care providers are general duty medical officers. These are MBBS doctors. They are not specialists, and they do not have any specific knowledge of occupational health because it is not covered in any undergraduate curriculum or postgraduate curriculum. The third aspect was building up capacities and utilizing these medical officers in the primary health centers as basic occupational health physicians. Finally, assessing whether this made any impact. And the mission was to execute it in areas which had 22 IOH branches. Now, the Indian Association of Occupational Health has branches in cities and states which are heavily industrialized. Areas which are not industrialized, IOH does not have a presence over there. So the areas were selected in such a fashion that only where IOH presence was there, it would be easier to conduct the training programs. So Mission BOHS, this was the plan. The goal was to improve the healthcare for this identified beneficiaries, and you have to try to control the work-related illnesses and injuries. Dr. Will referred to a manual which was presented to him. You can see the picture of this manual. This was created by us. It was a manual which talks and addresses those 22 informal industries, informal occupations. It talks about the magnitude, the number of personnel involved with there, the work processes, what are the hazards at various stages, and what are the potential preventive measures you can take care of. This manual is available for free downloading from the LDOH site and from the IOH Mumbai site also. So the objectives were to increase the capacity, increase the knowledge and the capacity to initiate the occupational services, and basically reduce the vulnerability of this high-risk groups in the vulnerable workers. The outcomes expected was a BOHS manual which was created, and 75% staff would be certified in attending to the OHS care, as well as bringing about finally a reduction in the work-related health complaints. First barrier, first challenge happened when we realized the primary duty care medical officers did not even ask for work history. Patients who were presenting in the OPD were treated as any other clinical case. Nowhere was a question asked, where do you work? What is your job? So this was the first orientation we tried to bring about the change, the perception in the attitudes of these medical officers by telling them to ask primarily what is the job of these workers. This took a lot of time. And before actually talking about the further slides also, let me just tell you that this was a project which was executed on a voluntary basis. There was no support from the state governments. It required millions of man hours to talk to individual state governments, health authorities, to at least give us a chance to start this training programs with the primary healthcare medical officers. And we started initially, we made a very small beginning. It started in 2015 in one state, Gujarat, where we were lucky to have utilized the satellite learning modalities for distance learning and could cover the entire 800 PHC medical officers at different goals in various stages, and then slowly proceeded to execute the program in bits and pieces in Maharashtra, Madhya Pradesh, West Bengal, then later Goa, Karnataka, and a few other states. And the tradesmen which were covered were fishermen, agricultural workers, sugarcane workers, tannery workers, roadside vendors. These contact sessions were sometimes through workshops, through BOHS lecture series, through collaborative training programs with the government, with any voluntary organization working in the field, and the satellite learning modality, as well as creation of these YouTube modules, which are available for use. What was required? Technical guidelines and OSH training for PHC staff was required. There was no orientation that was required. The budgetary allocation for PHC's OHS services was nil, and workplace risk assessment did not exist. So a situational analysis after execution of the mission over a period of almost 24 to 36 months, what did we find? That yes, this is a workable strategy. Training models were created in sync with the local professions and local employment. PHC medical officers did develop additional skill sets, but this was an NGO promoted campaign. So we could have a limited approach and a limited reach. Sustainability will happen only if the state health services take ownership. And a very important factor, there has to be a worker's interest and a worker's requirement. This was perceptibly seen as a deficit which was not available at any level. And regulatory enforcement and legislative provisions are necessary for the sector. When we assess the training programs at different states, what did we find? We found that the respondents were satisfied with the content. It was relevant. But there was a perceptible interest in knowing more about the behavioral issues among the informal workers and specific learning on occupation-based diseases rather than generic content. Simultaneously, as like BOHS, there have been a few other projects in the country which have attempted to provide occupational health services at local levels, at project level, at experimental stage. Prominent of which is a mini occupational health service in an urban market in the country. Then this Waste Pickers Association coming and working with the municipal corporation in Pune city and creating a cooperative, which very importantly worked on data collection systems, which is a big deficit in the country. Then there's a Mathadi Workers Health Scheme, which was concentrating upon reviewing the work conditions and providing basic protective social security, providing medical benefits and accident compensation. And two more examples. A very prominent is Seva Gujarat. This is a women's run mission. Seva Gujarat has been working for the past 2 decades in the country in this sector. And they have grassroots level women health workers which provide health education and referral services. They actually help the Indian Institute of Public Health and work with them to design tools for home-based workers and work in the area of primary prevention of occupational hazards with the ergonomists from the institute. So what were the learnings? Primarily, the initiative had paid more attention to creation of capacities amongst the medical officers and did not pay any attention on developing the nursing cadre. A very important learning was occupational health nurses and general health nurses, when trained adequately, provide efficient BOHS services, which has been seen in some of the other models across the world. But this is an area we did not actually pay attention to. The referral services are lacking. There is no National Occupational Health and Safety Board where we could send these cases and seek opinions and invite and find what are the specialized services that could be offered to these individuals. PHC-driven BOHS cannot be just general duty medical care, first aid care, accident care, and work-related health care. It has to move beyond the PHC, go into the community, at the workplace, and assess the risk at the workplace and understand the hazards as well as conduct the medical evaluations. Now, this aspect was lacking in this particular project. Database for registration of informal workers is very important, and we have tried to create a database. Now, there are certain schemes, central schemes, which have come in, which require this database. It is mandated, and this is in the offing. It is actually a work in progress. Capacity building of BOHS for medical professionals, allied professionals, occupational ergonomists, hygienists, they have to include trade-specific and job-specific elements of the informal employment. So for that, informal workplace-based internships work best. BOHS can only sustain with the help of regulatory support, legislative framework, and the requirement amongst the worker. So this requires occupational health competencies in healthcare personnel. Otherwise, it remains an experimental project. So a few recommendations at the end of the project. The project is still in the offing, but it is not actually going at the speed and the momentum that we would have expected it to.
That's 20 minutes, Dr. Suvarna.
Yeah, thank you. The last slide. It needs a collective will of Ministry of Labour and Health. They have to work in tandem. They cannot be working in silos, and this project then cannot conceive, cannot actually work. Employer associations and workers have to help in. A network of trade unions to collect data on OHS issues is related to informal sector is required. Universal health insurance for workers will actually be a very important financing mechanism for BOHS, and which can lead to universal health care. Trained community health volunteers and nurses can be an important delivery element, and focus on occupational health to be instituted since a very early age at the high school and university levels, capturing the digital technologies, the latest in educational technologies for mobile and e-learning. And finally, assessment of and audits of BOHS to understand what works. So this was basically an attempt to explain to you how we went about Mission BOHS in the country. It's still in the learning phase. If you ask me very frankly, there have been minimal gains. A lot of work requires to be done. And I thank you for your patience.
Thank you very much. Thank you very much, Suvarna. So our second presentation is by Professor Frank van Dijk. He's talking about opportunities and challenges in basic services and similar innovations in healthcare. Professor Frank is an occupational physician and professor in occupational health at Amsterdam University Medical Center in the Netherlands. Since 2014, he's working in the Learning and Developing Occupational Health Foundation, and he's a member of the Health Council of the Netherlands and is co-author of 200 international peer-reviewed articles. So welcome, Frank.
Thank you for inviting me. I hope I'm visible now.
Yes, you're visible.
Okay, and I try to share my screen with the. I have to go for the presentation now. Let me look. I hope it works. Does it work? Thank you. Okay, thank you. Well, I will talk about opportunities and challenges in the basic occupational health services, and also the similar innovations in healthcare, because in many countries they don't use the term basic occupational health services. So we included also other innovations, let's say in Brazil, but they don't use this term. We have no conflict of interest to report. And this lecture or introduction is also by Suvarna Moti. Well, just to make a start, here you see a picture from a publication on the medicines of Sans Frontières, the medicines without borders. They did a large experiment and study in Dhaka, Bangladesh, where about 1.5 million workers, for instance, are working only in the clothing industry, what they call ready-made garment industry, under very bad conditions, as you can imagine. Also tanneries, plastic recycling, and metal industry. So they did they built like a clinical center where they offered all kinds of services to selected industries. And they found out that a lot of workers were, of course, what you could expect, having occupational work-related diseases and injuries. And I showed it just to show you basic occupational health services can have different forms. This is a rather big scale form, but mostly it's smaller, but they are different. So keep in mind, it is a concept that is applied in various countries, but in different forms, dependent on the opportunities there. So what we are talking about is not less than talking about a new structure for occupational health care. As it started in most countries as an expert-based occupational health service, mostly for large and medium-sized companies, sometimes for high-risk companies, especially like mines. What we are now talking about is to enlarge this concept to maybe including two forms. The second form then is basic occupational health services. And you see that this is mostly integrated in primary or community, maybe public health care. If you see it, if you make a scheme of that, you may imagine something like this. Now you see, if you look at the workers in the bottom line, you see workers in large and medium-sized enterprises have some support in the green arrows, and some care as well from occupational health care services that are also giving some support to employees of small enterprises. But what about informal workers, self-employed, and also the future and retired workers and the unemployed workers? They have no or very limited support from primary care, healthcare, and community healthcare. So what you also can see is that the occupational safety and health experts, like physicians and engineers, they are working mainly in occupational health services, and they have not connection with informal workers to give example. If you go further and you say, what when I was the director of a country or a government, I would have some improvement. Well, in this picture, it's too complicated to say it in a few words. But what you can see is that you can try to, of course, you can improve the occupational health services for the employees in large and medium-sized enterprises, and we should do. But at the same time, we need also new provisions that we call basic occupational health care, integrated or in primary or community health care. And so you see that care and support is now much better organized in the country, also servicing those workers that are mostly working in higher risk areas like informal workers and the other group self-employed. Also, of course, workers in small company. So what you see is that you need a new structure that is not departing only from the Ministry of Health in the sector of labor, but also has a big component in healthcare integrated not only in the primary and community, but also in hospital healthcare, where you see in many countries that specialized occupational healthcare is there, that is also able to support primary healthcare and occupational health services. So occupational safety and health experts are not only connected with occupational health services, but also more directly connected in hospital or primary healthcare efforts. So what we did not long ago is we made a repository and database with all kinds of literature that has been published since about 2000, a little bit earlier sometime, on the internet that is free available, and I will show you what is in that. And we also have written a scientific article, and you can download both free. This is the start of the repository. I will not go into details. In the next slide, you see more details. Here you see two publications just as examples from China, 2010. And they will tell you a lot about the experiments done there. I will go into that later on. And you can also get this publication easily by clicking on the links at the right side. And you can find some details about these publications in the other columns if you like to look at that. So in this way, this repository is free, available for everyone, and you can go to that. And if you want to do a study or some orientation, you can use those publications. But to come a little bit further, Suvarna and I, we decided to define some topics, some themes, to get more grip on this wide area of healthcare development. What it is, it's basic occupational healthcare development where we are talking about. And so we decided to make 4 big teams and some 16 sub-teams. Just we go a little bit through that, not in detail. So we say, okay, first you have the phase of a start of BOHS. And you have some sub-teams in that, let's say, public awareness of the risks, workers' healthcare that's often failing. You need experiments and you start a national policy. In the next phase, we are talking more concrete about the structures that are in the legislation, prescribed or regulations. Financing is, of course, crucial, but also we can talk about the coverage that is intended of what kind of worker populations, not only the industrial populations and the formal positions involved, but also the other ones, and the tasks. In the next phase, we decided, in the next steps, I must say, it's not a phase, we have to decide that to look at the infrastructure. That's often forgotten. You just listened about some aspects of that in the talk of Suvarna Moti, that you need to have good education, you need national and regional expertise centers that are supporting primary health care. You need online facilities and a referral system. So we decided this as sub-teams that are also very important. The last one is about quality in practice. So what are they doing? Is it a good mix of mixtures available? Are they having good competences? What is the management quality, the engagement of staff, the quality of the services as they are provided, and do they have evaluation systems? So we go through it a little bit more in detail now. So in the phase of the start of BOHS, you can look at different challenges and opportunities. This is, in the challenges you can read it. I will not name it in all details. There's a low public awareness is one of the problems. So what you can do as an opportunity is do an awareness raising program in the media. Some details, I will not show all of these slides, are found in the publications that are mainly from the repository. For instance, this, what are the problems in START? In this case, I selected the experiments that are done. One of the most important experiments are from Thailand. The next speaker will go into that more in detail. But also, let's look at the second one, is in China. In China, there was an experiment you can read here about that they included capacity building, training, and education. All kinds of aspects were included. It was rather a complete BOHS system that they have built, especially also for the migrant workers in China. They have about 250 million there. And this system was evaluated after a few years as well accepted by workers, cost effective, awareness was increased, and also very important, you can see that the employers and governments were sharing the financing of the system, while the government paid for the self-employed and informal workers. Is of course there we need another regulation. BOHS finally covered no less than 1.9 million out of 2.3 million in 2008. Some of the next publications, I will not go into details, are discussing these experiments. And you see also in yellow some critics on this. The informal sector stakeholders' involvement was low, so it was not participatory enough. And there was also a lack of human resources, especially, of course, of occupational safety and health specialists. You've seen this, the experiments in India. Suvarna talked about all these industries. And it was also in, let's say, Latin America, you have nice experiments done in agriculture. And also in Southern Africa, you'll see that some experiments were done, although not on a large scale. Really a big problem there in government activities. So but there are still very nice examples of new experiments done. In the second topic, second theme is about the structures. And you see here a lot of challenges. I will show them later more in detail. But one of the most important ones is, of course, the legislation. Outdated legislation only covering regular employees is one of the most crucial problems that we know. But also other ones, like also incomplete services. For instance, the rehabilitation service is often limited in many countries. So we have in the repository many studies. I will not go to the Thailand study because that will be done after my talk. But for instance, Brazil is very interesting. The legal structure in Brazil is such that in the Constitution of 1988 and also in later lawmaking, it is regulated that the primary health care is responsible for comprehensive occupational health care in Brazil. This is unique also in the world, but also unique in Latin America. So they have also national policy documents, and they point the way how important worker care is within the scope of primary care. So we found a lot of studies later. I'll show you one or two showing that we really have some interesting area in Brazil to look at. The third theme is about infrastructure. I talked about that, education and support. So not only the structure has to be okay, we need absolutely support structures, otherwise basic occupational health care simply will not survive or get dismotivated. So this infrastructure is very wide, and you'll see what we all know, there is limited or no education in occupational medicine in most countries, limited facilities for professional education of professionals. There's no national institute. We can look at ILO, that has very good, a very good recommendation on the infrastructure. Also stressing the importance of a national institute, to give an example. Regional support, I will go into that in more detail. Regional support is a very interesting issue. In Indonesia, 2012, Hanifa Denny published a doctoral thesis on this with support of the University of Florida. They have centers, but not so many, that are supporting the primary health care with occupational health referral services and with other support. And they could prove, she could prove that there was improved knowledge and engagement of occupational health among the workers and health officers in the primary health care through this support center. So West Java and Central Java were different in this respect and were compared. Also important is that the local governments, that's important in several countries, also in Thailand, local governments have to pay or have to give other support to primary health care in order to get basic occupational health care. So that was also improved by these centers. So they were really supporting, to convince local issue to support basic occupational health services. Then you see here in Brazil, and we have many publications, about 40 publications from Brazil in our repository. You see that Workers' Health Reference Centers, they have the name CERES in Brazil, are very important. They are effectively supporting the occupational health in primary care practice, as is shown in several publications. Of course, they're also complaining about lack of support. We cannot do everything alone. To give just a statement from a qualitative study. And new initiatives, I don't know the evaluations of that, but they are interesting to look at because they are online, so it's important nowadays. Ministry of Health did start an information panel on environmental and workers' health, and did start an online network for comprehensive care to workers' health. So you see that it's not only regional support, but also online support nowadays that can be very important. Want to go to the last study here, it's Amorim. Workers' health activities of, they call it family health teams in primary care, was supported by the center, the CERES centers, that was reported by 45% of the physicians and nurses in a study in one city. And of course, they still think that team support and education should be extended. So this is an important note that you can see in the different areas in the world, that that the support of the primary health care, the basic occupational health activities there is a crucial element we should not forget. Some other studies, one I just want to stipulate in the United States to make a new area, to show a new area. There you see about the same, that you have community health centers and the clinicians there want the ability to refer complex patients to specialists in occupational health or clinical ones, and to get advice by telephone consultation. So here you see the same. If you don't have an infrastructure, primary care or community health care will fail because they feel alone, they feel they don't have good experiences, they even can get negative feelings because they feel that they are failing in their care. The last topic is about quality in occupational health care for the basic application. All kinds of quality elements are here. I will just show some studies giving some details.
Frank.
Yes. I want to focus on occupational health nurses because they're so very important in this presentation. So different studies are showing, this one is from Thailand, the final recommendation of this study is to appoint occupational health nurses as mentors and consultants and educators, supervisors. The second study is also from Thailand. It's about the development of the occupational health service competency scale for nurses. And those competencies are not the same as for occupational health nurses working in large companies. And you see here also in Brazil a study showing that this kind of practitioners are needed and that professional training is crucial. And this study shows that only 3 of 16 professionals in the region did have professional training. What is really a bad position too. Well, in this slide is just as was given before. So I will not go into these details. It's showing that both in all 4 areas of the starting, the structure, the infrastructure, and the quality that you can evaluate. There are different recommendations in this slide, what we had a short talk about. Finally, we are planning to start, I must say, a BOHS working group, because we see that in different regions of the world, many people are active as a pioneer, and we think that it is worthwhile to share our experience in the world and to have also some opportunities to make studies and to encourage each other and to make publications and to do some promotion for the basic occupational health services in the world. So we will start this working group. We still will work at the repository as we think it's a good point of departure, as hopefully I could show you a little bit of that. And last but not least, this repository needs to be updated and enriched. So if you want to share with our work, you're welcome. Finally, I just show you some references I used for this short talk. Thank you for your attention.
Thank you very much, Frank. That was great. So we'll move on now to our third and last presentation. There was a schedule published put in the chat at the beginning saying that this would be the whole webinar 1 hour. We've actually extended it to 90 minutes. So we'll actually be finishing in 40 minutes. So we have time for the third presentation, and we also have time for discussion and Q&A at the end. So I hope you can all stay with us. Our third presentation is by Dr. Orrapan Untimanon, and is on the success and challenges of BOHS in Thailand. Dr. Orrapan is an occupational health epidemiologist by training. She's worked in the Department of Disease Control of the Bureau of Occupational and Environmental Disease in Bangkok, Thailand, for 17 years. Her current project focuses on the development of occupational health services provided by hospitals and primary care units, and the development of occupational health services for health workers. Dr. Orrapan.
Thank you, Dr. Will. So may I share my screen?
Yeah, we can see that. Thank you.
Okay, thank you. Let me see. Okay, good evening from Thailand. Thank you for our audience for joining this session today. Today I'm here to present my work, the success of challenges of basic occupational health services in Thailand. In my presentation today, I would like to explain 3 key points, including situation of informal worker in Thailand. The second one, the informal worker and occupational risk also I mentioned today. And finally, I will focus on Occupational Health and Safety National Intervention Program that we implemented in Thailand. So let me start with the situation of employed workers in Thailand. In last year, there are totally around 40 million of employed person. Of them, informal worker is a bit higher than formal worker. It's around 50%, but it's a informal worker a little bit higher than formal worker. So we divided the occupational group into 3 groups, including agricultural setting, manufacturing, and service and trade. You can see that among informal workers, we found the highest proportion are in agricultural setting or farmer, followed by service. For example, like a salon, motorcycle, and car or taxi driver. It is a 3 group of informal workers. And also among formal workers, we also divided in 3 groups as well. So this picture, we can see that this is the information from the national survey last year. You can see that among 21 million worker, employed informal worker, when we survey, we found that around 6.9 million of informal workers face the occupational hazard, or around 28.2%. The occupational health hazards, such as the first one, we found the largest, the proportion that they face with the chemical substance, followed by the working condition, and the number 3 is like dust, smoke, or smell. Is the proportion is around 23%. So in Thailand, when we conduct the project, in the beginning, we focus at like a 5 group that we call a high risk group of informal worker. The first one is in agricultural setting, or we call like a farmer, that they have to face with pesticide, economic, and heat. Especially right now, the temperature in Thailand is a summer, so it's around more than 30 degrees Celsius. So they have to face with like the heat, and also accident. For the second group, is a garbage man, that they have like a collect or waste, both general waste and also electronic waste. They have to face with biological hazard, accident, heavy metal, for example, lead contamination or cadmium. And the third group are stone carving. Stone carving, they have to face with like a silica dust, noise, economic, and accident. The garment worker who work with, they have to produce many kind of clothes. They face with dust, biological, economic, and accident. And for the driver, not only taxi driver, motorcycle driver also is a large group of informal worker. Then right now, after COVID-19, we have like a gig economy group that they have to ride the motorcycle to delivery the food or other trade, something like that. This is, they have to feed with economic, heat, biological, and also the environmental problem, PM 2.5, that have like in Thailand also right now, this environmental problem in especially in the big city. And also they have like to got accident, not only it's only traffic accident. This is the 5 group that when we conducted the project, we mentioned these 5 groups at the beginning. So I will move to Occupational Health and Service and Safety National Intervention Program. You can see that this is the health services hierarchy in Thailand. Among Ministry of Public Health, we have at the sub-district, we have primary care unit. That are a key mechanism for providing health services for all because their locations are close to the community. Right now, around 1/3 of primary care units have moved from the Ministry of Public Health to be under the local government because of the health decentralization policy in Thailand. And they are totally, right now, there are 6 provinces with 100% of primary care unit transferred to local government. But for other, it's around 2/3 of primary care units still under Ministry of Public Health. And at the district level, we have like a community hospital, around 800 hospital. And we also have like the provincial hospital that around 130 provincial hospital. Not only the government part, we have a private hospital around 400 that they can provide the occupational health services as well. So we developed the occupational health services that Dr. Frank mentioned maybe more than 15 years. But in 2015, we scaling up from the coverage of the occupational health service provided by healthcare provider. And we are scaling up to be develop the quality of the occupational health services. So the aim of this project, we would like to increase the coverage of occupational health services and to develop the quality of occupational health services delivery. And lastly, we would like to address on the occupational health and safety among health workers as well. So step of implementation. This quality assurance system has been established since 2015. So we start with developing the tool that we call standard or guideline that I will be mentioned in the next slide. After that, we set up the quality assurance system and integrate with the existing system such as hospital accreditation. And then we collaborate with related agency, especially in the regional Department of Disease Control, provincial public health office, and other to support healthcare providers. And finally, we train the auditor. We developed the curriculum to train the auditor and audit the participant healthcare providers. So in this slide, the standard of occupational health services, we divided into 5 components. The component 1 is we mentioned on organization management, for example, policy or the plan or the competency of the healthcare staff and so on. And for the second component, we focus on occupational health and safety for health workers. So this because we pay attention to healthcare workers as well. And the third component is this is, I think, related to informal worker. We provide the proactive occupational health services like a walk-through survey, risk assessment, or health education, or also the health examination and database establishment. And the fourth component is focus on in-house occupational health services that are like screening or give diagnosis and rehabilitation, something like that. Lastly, the proactive environmental medicine service. This is maybe we pay attention to the not only the worker, but to the other population that affected from environmental problem. For example, PM 2.5 or lead contamination, something like that. And the standard of occupational health services, we divide into 4 levels, depending on the performance of the primary healthcare unit. So we start with the starting level, good level, very good level, and excellent level, depending on the performance of the primary care unit. So this is the number and percentage of healthcare provider whom passed the standard of occupational health services. So 30% of the primary care unit could pass the occupational health service standard. And only 10% of primary care unit under the local authority could pass such standard, when more than 50% of the community and provincial hospital could pass occupational health standard, because maybe the provincial hospital or community hospital, maybe they have like more ready. For example, like human resource, like me, they have nurse, occupational health nurse, or occupational health physician. But for primary care unit, they have only the public health technician officer. Because of the primary care unit under the provincial administrative organization or local organization, they just moved to this from the Ministry of Public Health maybe 3 years ago. So right now maybe it is the time of the like transitional. So some primary care unit did not provide occupational health services right now. So I moved to the training course for occupational health personnel that we have established in Thailand. So right now we have around 10 curriculum that under Ministry of Public Health. Start with occupational health for nurse, that we have the duration of training is 10 days or 60 hours. Right now, this is a regular training course in Thailand. And for nurse, also we have certificate of nursing specialty program in occupational health nurse. This program we collaborate with the university. This is 4 months and fit for registered nurse. And for the physician, we have occupational medicine course that have duration 2 months. And after that, from number 4 to number 10, most of curriculum is for public health technical officer and also for nurse. And I will mention in number 8, the fundamental of occupational health for health personnel that we developed after COVID-19 because of we could not face-to-face training during and after COVID-19. So this program start and open in February last year. We have 12 hours. This course is fit for public health technical officer. And also right now, we also develop the curriculum that focus on international basic occupational health services that have duration 5 days. And lastly, we also develop environmental and occupational field epidemiology that we merge with the field epidemiology alumni. So number 9 and number 10, right now we just finished the curriculum, but the training for the pilot is in the plan. So I will tell you more detail in number 8. Number 8 is the online training course for public health personnel. This is the specific objective of the training is, after completing the training, we would like to set that the public health personnel will be able to describe occupational health situation, problem, and plan for the area with their primary care unit are located. And we would like they to have or identify occupational health hazard. And they can conduct risk assessment and management. And also, finally, they can deliver both passive and active occupational health services. So this is of the duration 12 hours. In the online training, we have 7 subjects in this course. Start with occupational health situation and occupational health strategic plan that have around 1 hour. Work to survey and case study. Risk assessment and management and case study that we have 2 hours. Occupational health legislation that we have 2 hours. Common occupational illness in the community. Concept of occupational health services and case study. And lastly, we also address on ICD-10 record keeping for occupational disease and case study. And the course had begun since February last year that I mentioned before. Currently, around 1,500 public health personnel could participate in the course. Of them is only 50% could finish and got the certificate. Some person maybe they start, but they did not take the examination, or they did not study whole of the curriculum, something like that. And around right now, it only 50% could finish. So the last implementation, I would like to tell you about the occupational disease data system that through Health Data Center of Ministry of Public Health, we insert 14 occupational disease, including toxic from pesticide, work-related musculoskeletal asbestos, mesothelioma, silicosis, noise-induced, and also occupational heavy metal poisoning, VOC poisoning, or lead poisoning, heat-related illness, skin disease, asthma, and occupational injury. We insert in the Health Data Center, and we try to convince the public health, the healthcare personnel to put the record this occupational disease. And also, we also put occupational health screening. For example, occupational health vision test, spirometry, audiometry, chest X-ray, organophosphate and carbamate exposure screening using choline ethylate reactive paper. That is a screening for people, for farmers who export to pesticide. So this is the diagram that show how data flow to the Ministry of Public Health. Start with the service provider, for example, hospital or primary care unit, that they have like information like medical record that including clinical diagnosis, laboratory, X-ray, or pharmacy. Right now, I think most of healthcare provider, we have electronic base, but maybe also only a few that have a mix, have with paper base. From this, they export data to have like inform of Health Data Center data set and the clean data. This state is individual data. After that, they were sending to the provincial health data center. After they will verify and analyze data. And after that, they report to Ministry of Public Health, Health Data Center. This the process is aggregate data. So this is the flow of data of not only occupational disease, but also for other disease that did put in this flow. So after that, the dashboard of occupational disease that can show in is open data. So however, we implemented the occupational health services project for like more than 10 years, but we also have limitations such as lack of knowledge on occupational risk management among healthcare providers, and indefinite policy and specific budget for occupational health services. And due to the health decentralization policy, the voluntary primary care unit are transferred from Ministry of Public Health to the local government. Currently, the facility, staff, budget, and other resources of such primary care unit are moved. Therefore, the whole healthcare system is impacted. So this is the last slide that I would like to tell you regarding the necessary step toward the future. So the policy advocacy that still have to conducted. Health examination related to work for informal workers is being proposed to be the benefit package of universal coverage scheme. Right now for the UC or universal coverage scheme, we also treat like do to general disease or prevent for general disease, but prevention and health promotion for prevent from work, we did not cover yet. Capacity building for all related personnel following occupational health services, including health promotion, leading to occupational health and safety and well-being among community workers. Improvement data system for recording and reporting occupational disease cases or other occupational health services activity. And we would like to continue collaboration among Ministry of Public Health and the local government organization to sustain and extend the occupational health works. So thank you for your kind attention. I can open to further discussion and feedback. Thank you again.
Thank you, Dr. Orrapan, and thank you to all our speakers for three excellent presentations. I'll start off with a kind of question to the panel, and if anyone else has questions, please post them on the chat. So in the United Kingdom, we have a problem, like many other places, with occupational health cover for SMEs. We've just kind of formed an expert committee to look at this and look at how we provide services to the small and medium-sized enterprises. So what advice would you give that panel on what lessons can we take from BOHS?
Shall I take it first, Frank and Orrapan?
Yes.
Okay. Thank you, Will, for that excellent question. In fact, that is something that we also have been struggling with, that issue regarding the provision of services at that level, SMEs. So perhaps what would be important over here is if you have general practitioners, like what we've seen in Manchester, where the general practitioners were trained with a diploma in occupational medicine, and the general practitioners supplemented with the services of an ergonomist or occupational psychologist and occupational health nurse, and with the workplace provision of services. This perhaps is an idea you can think of. Now, the financing for this could be a part of the NHS or the social insurance also. Frank, your thoughts on this?
You're on mute, Frank.
Yes, sorry. Yeah, one option in the UK, of course, is that you have so many GPs, that general practitioners, for all the other people in the world who don't know what GP is. It's a family physician, and some of them are trained in occupational medicine because of the sickness, or called a fit note. And they can have office hours, as a beautiful experiment done, written by the Beckley study, that they show that this kind of office hours are very productive. People can come with work-related problems to the general practitioner and have some special attention for that. That's an option. And of course, occupational health nurses could be connected with the primary health care and giving an office hours special attention to those who want to speak about occupational health problems. This is also a structure that was experimented in the Netherlands. It was very successful, although after that there was no money for that, because there's no problem owner who is advocating for this. So you first need a coalition with unions and progressive employers. If we have them in the UK, I hope so, that they join in this, because then you can look for experiments, and after you can look for financing. So having some experts, occupational health nurses or GPs that are trained in occupational medicine, you have a lot trained in Manchester, for instance. And so you can build up with experiments and build up the financing, that in your primary healthcare there is some office hour for the problems, and that will give attention to the issue, and that will broaden the issue later on. That's my advice.
Thank you. Dr. Orrapan, do you have anything to add? You're on mute, Dr. Orrapan.
Okay. For healthcare personnel in Thailand, at the primary care unit level, we also have a nurse, but it's a general nurse, not occupational health nurse. So right now we have to develop the competency of general health nurse in primary care unit as well. But in a community hospital or general hospital, we at the community hospital, we have occupational health nurse, but not more. Is around maybe 50% of community hospital. We have occupational health nurse, and also the occupational health physician. We lack of occupational health physician. Most of them are in private hospital and also in provincial hospital, and like a center hospital that they have more than 1,000 beds. Then they also have the occupational medicine or occupational physician. For financial, we have in Thailand, we have universal coverage scheme that include informal worker, but not specific for occupational health services, either health examination, audiometry, something like that. Right now, did not include in the universal scheme. For universal scheme is only general disease that they have to like the cure, focus on the cure or how to treatment. But for prevention or promotion, right now we try to develop the policy. Thank you.
Thank you. We had one question about cover for agricultural workers. Agricultural workers often work alone or very small numbers, family farms, etc. They have lots of health hazards on the farm, chemicals, animals, etc. So how does BOHS work for agricultural workers? The panel.
Orrapan, do you want to take this question?
For farmer, or pardon, no, I did not hear clear.
Sorry,
it's a farmer.
Just a question about how does BOHS cover agricultural workers? How do you reach them? Because often they're working alone or very small groups, often family farms, and they're
okay.
They're an occupational group that have a lot of hazards.
Yeah, because we are we walk to survey or identify the hazard that through primary care unit. Also is the health volunteer. The health volunteer who work close to the community worker. Volunteer also community worker or also informal worker. So we develop like the training the health volunteer to take like walk to survey or ask or survey the informal worker who face with several hazards that you mentioned.
Thank you.
Yes, I think the same. But there are two approaches in the world. One is more academic one, started in the US and expanded to Turkey and especially Australia. That is from Dunham and Susan Runby. They have written a book and have a beautiful course, but that's more a specialist course. On the groundwork, you indeed can look at what Thailand is doing. Agriculture is one of the main reasons to start BOHS, not only in Thailand, but also in Indonesia. So this is indeed a good model to look at. There you will see that in the primary healthcare in those rural regions, you will get some experts and some experiences that have to be supported, and then you can make progress. Yes, sure. Especially primary healthcare is in a position to do that.
Yeah, thank you.
Let me share our experience in India. We have a huge agricultural informal industry in the country, almost 58% in that sector, working in that sector. But there is a lot of defragmentation over there. In the sense, what happens is when it is pertaining to training the agricultural workers about use of tractors, use of heavy machinery, then it is that specific engineering group with the Department of Agriculture, which moves into the field and conducts the worker training sessions and monitors some of these sessions, workers about the likely hazards, how they have to tackle them. Similarly, when it is pertaining to use of pesticides in the agricultural sector, again, it is the Department of Agriculture which teams up with the the manufacturing associations, the pesticide manufacturers, and conducts the worker training sessions to provide perhaps to some extent some risk assessment as well as actual inculcation of training as to how the pesticides are to be handled, safe handling of pesticides. So these aspects are covered by the specific employer or the manufacturing associations. When it comes to conducting risk assessment in the farms per se, or a walkthrough survey, unfortunately, that facility and that functionality is neglected. It does not happen. But provision of first aid, provision of care at the primary health center, that is very actively pursued. So this is how you can say the occupational health services, some aspects, some elements are delivered.
Thank you very much. We have a question about occupational hygiene and how does occupational hygiene fit into BOHS?
Well, I see in several publications that occupational hygiene is stressed by in many studies, that it is an important element. But it will be in a position like also is valid for occupational physicians. They are more in the second tier, in the district level, coordinating, being available for referral and for telephone advice if there is a complex case. So I think that like cardiology, occupational medicine is moving towards a second line approach where we are not doing the everyday simple questions that will volunteers do, or nurses do, or community health volunteers, or community health who are professional. They will do a lot, but hygienists and doctors and psychologists and other experts, as we need ergonomists, not to forget safety, they are more in the second line. They are training people, they are supporting, they're giving advice, and they are available for referrals. And so they are strengthening the whole system, like a cardiologist is doing. He's not doing the blood pressure measurement control every day. So this is, I think, that we should do, looking at reallocation of our experts, not only to the large firms where the risks are low, but reallocating to those workers that are informal, that are in small companies where the risks are high. And so we have to move towards a new future. That's my opinion.
Thank you, Frank.
Let me just share some of our experiences over here. What happens is, if you see the stage 3 of BOHS services, we talk about bringing in this allied professionals, like the occupational hygienists, the ergonomists and all. And in the established industries, industrial hygiene is definitely wanted. The services are provided. But in some of the formal industries employing contractual workers or so, the provision of industrial hygienist or an occupational hygienist is not always assured. And those are the areas wherein the safety officers are trained to continue to deliver the function of an occupational hygienist. So this is a paradox which we see.
Thank you. Thank you very much. Well, I'm afraid we've run out of time. We still have a few questions to ask, but I'm afraid they'll have to wait for another day. Thank you very much to our 3 speakers. I think this is a fascinating concept, and I look forward. As I said, it first caught my attention 5 or 6 years ago when I visited India, and I'm very interested to see how this develops, and also how these concepts around the world, and how we can learn from them as well. As I say, because we're all facing similar challenges. So thank you very much to our panelists, and thank you very much to everyone for attending.